I am thrilled to welcome y'all back. This session is supposed to be focusing on innovations and thinkings about supporting people who are and have been unsheltered. But you'll see that we actually have a range of conversations that are happening in this panel that I think will get a number of the issues we've talked to in previous sessions as well. We needed to reconfigure the order of presentations today. So I think everyone will put on their thinking caps to actually be able to draw the connections between all of the talks. And I know everyone can do it. And so we're going to get started, and I've lost my screen with who's going first. So I hope the speakers know their order, and I'm going to let everyone introduce themselves as I have been for the past sessions, because that seems to work a little better. Thanks.
Dr. Ware, I believe you are the next.
Okay, so the genesis of this research is that when I was working at a homeless organization, my office was right next to the meeting room for all of the outreach workers that worked in our community. And I was really impressed by these people and their ability to reach out and connect to people on the streets that were really hard were really resistant to receiving services. They built relations with them, and they were able to move them very often back into housing. So recently, so I continued doing some of this research, and I published earlier this year some analysis about doing a comparative cost analysis of emergency shelter versus street outreach to see whether we should be putting more money into street outreach. And in a nutshell, I really found that street outreach is a relatively cost-effective program compared to emergency shelters in terms of the expenditures that you needed to put in to get people housed for a certain period of time. And I just measured that over 2 years, beginning with their initial engagement with the system. And then another inspiration is LAHSA's recent report from the Ad Hoc Committee on Black People Experiencing Homelessness. They did a deep dive in this report on permanent supportive housing. And interesting, they found that there was no bias apparently against African Americans in terms of accessing it. In fact, they were slightly more represented in the population of PSH than they were in the general homeless population. But what they did find is that Black people in PSH in Los Angeles were much more likely to return to homelessness after a period. It was about twice as likely for individuals, and it was about 4 times as likely for families. So that was a really disconcerting result. So I wanted to return to my work on homelessness outreach and see whether there were similar disparities in ways that were impeding Black people from outreach workers from helping Black people. So the first thing that I did is I just looked at the racial makeup of the outreach clientele. And there I very quickly had some cause for concern, is that they were underrepresented. They were 49% of the people if you just look at the either the Black or the white clients within the system, they were 49%, but only 44.3% of the people who were in street outreach. So they were underrepresented. And then I went to the most recent PIT count for Sacramento, where these data are from. And again, you saw something similar, that while in the sheltered count, they had 40% of the sheltered count was Black, of people who were Black. It was only 31% for the people who were unsheltered. So that really raised a question whether there was some implicit bias going on who you were reaching out to. So I was very concerned about this. So I dug a little bit deeper into the data, and I looked at another data set that I had used previously. And there, when I was able to separate between single adults and families, I got very different results. Is that there was no disparities among single adults, that they were the population in street outreach completely reflected the populations in the broader homeless population. So that was a little bit reassuring. But what was going on is that among families, Black families were less likely to be enrolled in street outreach programs. Then I dug in a little bit more deeply on all of this, and it really explained, I was able to explain all this, this paradox is that all families in Sacramento are much less likely to enroll in outreach. Over 40% of single adults engage in street outreach, but only 10.6% of families with kids are enrolled in street outreach. And Black families comprise more than 50% of this population. So really what was going on is that it wasn't so much that there was some implicit bias and resistance to enrolling Black people into street outreach. It was more just a reflection of the different population makeup of people in Sacramento. And there was in fact a slight silver lining on all of this, in that Black families were more likely to enroll in rapid rehousing, which was the main program that they were trying to move families into, rather than either having them go to shelter or remain in street outreach. So that was a good piece of news. Now that I've solved that, and I don't think that the enrollment in the program doesn't exhibit some level of bias, I still wanted to look at the effectiveness of this program. And here again, there's some worries. Just as like you saw in the Los Angeles study, the Black clients of street outreach are more likely to return to homelessness. A little bit more than 15% of them return to homelessness in Sacramento compared to white clientele. So there's a possible source of concern there that maybe the quality of relationship building that's occurring within street outreach is not quite as strong for all these minorities compared to members of the majority race. So I wanted to keep on digging and figure this out a little bit more. But interestingly, now when I looked at other metrics of success once you enrolled in street outreach in Sacramento, that some other metrics were much more positive. So if you looked at the people who initially enrolled in street outreach, who ended up in subsidized housing, and for that I include anyone who is subsequently enrolled in transitional housing, rapid rehousing, or permanent supportive housing, in that case, Black clients in street outreach were actually slightly more likely to get those services compared to white people. So that was encouraging. And then the other thing that I calculated in this study is that from the initiation, your initial enrollment in a program, how many years were you housed, either sheltered or housed, over the next 2 years. And when I counted up all those days, Black clients actually had slightly more days housed compared to either whites, Latinos, or multi-race. So again,
I'm gonna just politely interrupt you to do a quick ping on time.
Okay, I'm on my last slide, so okay. You got me. So in fact, if you go back, that I started all this with thinking about a comparative cost analysis, and you re-examine that comparative cost analysis with a racial justice lens, the fact that Blacks on average are housed more days after an episode of street outreach strengthens the argument for shifting more resources towards street outreach. So let me wrap up. So the first thing is that, what did I learn from doing this little add-on study to my paper? The first one is that you got to watch out for something called Simpson's paradox. Simpson's paradox is a statistical phenomenon where the association between two variables, and in this case, it's between race and access to homelessness services, it can be flipped once you controlled for a third variable. In this case, it was family structure, individuals versus families with kids. This is not uncommon in statistical analysis. So it just is a warning that whenever you're examining anything about racial disparities, it's key to check that there's not alternative non-race explanations that may be showing be the cause for your initial result that there are disparities between racial or ethnic groups. Also, looking at outreach outcomes, the various metrics tell a complex story about the service experience of people's experiencing homelessness and how that intersects with race and ethnicity. And there's certainly reasons to be concerned that all clients are treated equitably, but the exact sources and forms of discrimination can be difficult to detect. And understanding the intersection of race and ethnicity requires taking multiple perspectives on the data. And digging deeper can potentially reverse initial assessment. So it's really important to keep an open mind. And the model is that you end up with a very nuanced picture of what's going on here. And it's exactly these types of nuances where there are areas where qualitative research, where really going and talking to people experiencing homelessness can really illuminate what's going on and what is explaining the fact of why people are returning to homelessness at higher rates, but at the same time having greater success going forward. Thanks.
Thank you so much. We appreciate it. Looking forward to the Q&A at the end. Again, just a reminder to folks to be putting those questions in the chat. Next up, we have Dr. Brian Chan from OHSU talking about the results of intensive primary care.
Okay, thank you guys. And let me just pull up my slides. Everyone can see the main screen?
Yes.
Hello? Okay, great. So I thank you for the invitation to speak. For those of you that don't know, just I think I'm also going to talk about our perspective in intensive interventions for medically and socially complex patients. And this stems out of a project that I've been working on for the last couple of years on actually what started out as a hospital reductions program, but I think as I'm going to present today, how it's kind of pivoted to a health equity lens. Just some background about my organization, Central City, actually is a multifaceted social services agency with housing, federally qualified health centers, employment services, and sobering services. And that we're a unique intervention in a unique setting. 77%, a lot of our clients have experienced homelessness. Half our patients have active substance use disorders and very, very low incomes. The intervention that I was evaluating is called Summit. It's basically a multidisciplinary team of team members with really high, low staff to patient ratios, flexible scheduling in the outpatient primary care setting at our FQHC to build relationships, provide outreach, timely support, increase access to team. And so these were patients that, were deemed really, despite having all these resources available, patients were still not engaged. Some of our patients were still having difficulties engaging in our care. This is a description of our sample. As you can see here, 31% indicated a minority status. There was overrepresentation of these folks over the general demographics of our population served. And then also noting that 57% were not permanently housed. So we did ask pretty detailed information and collapse those. And I'll also point here that 86% had gross incomes last month of less than 1,000. And so really at high risk for homelessness. I'll briefly just touch on the main results and then jump to kind of the lessons learned. But as you can see here at 6 months, we did not see any statistically significant differences between intervention and kind of our waitlist control, our usual care groups and hospitalization rates and ED visit rates, but did see higher rates of engagement in outpatient services. And we also looked at patient-reported outcomes at 6 months and saw improvements in mental health aspects of quality of life, which is a little bit surprising as our intervention was geared more toward kind of physical and medical complexity, but and I think I'll use this one patient as an example of why we might have seen this. This is a 26-year-old African-American man who, as you see here, the orange bars show after he engaged in our intervention, had actually higher rates of hospitalizations, higher rates of length of stay, ED visits, and primary care rates. And why is that? And as I'll kind of outlay here, these are some of the multiple issues that our team had to deal with that aren't traditionally that traditional systems have difficulties addressing. Frequent utilization of hospital services due to nausea, vomiting, electrolyte imbalances, deep mistrust of the healthcare system, often re-traumatizing every time you went to the hospital. So medical racism, housing instability, complex pain, and opioid safety. These are what the interventions the team was able to do to address his needs. So they supported a move to a new adult foster home, enhanced connection to GI and surgical specialists and dietitians, connections for a new ostomy nurse for a new supply plan, and so on and so forth. So I think one of the big things I wanted to bring across here is that as we think about traditional medical care, just because you have access to healthcare does not mean you can get connected to the services. Just like we talked about in the earlier sessions with vouchers, just because you get a voucher does not mean if you can get it. We solve housing. Complex care changes during COVID-19, social distancing measures, lack of PPE in our clinic led to immediate work from home arrangements. We had to rapidly switch to phone appointments. The team started using Microsoft Teams that fostered connectivity amongst team members that couldn't kind of be in the same room. We had no or limited in-person outreach. This impacted the social worker, nursing, and pharmacist positions most because they did a lot of the physical outreach. And all of our behavioral health services went virtual. There were downstream impacts to the safety net. So limited specialty appointments. We couldn't get into those GI appointments or those cardiology appointments for our patients. And then social services were extremely limited. All the housing offices, DMV, had severely limited hours and access that deeply affected our patients. And then ourselves, we lacked testing capacity, PPE availability. And then on top of that, the internal reckoning with George Floyd and systemic racism within our own institutions. And I think as a healthcare system, we have our own reckoning that we are dealing with. And so this represents the change. And just briefly, that we rapidly switched to phone visits, but not so much video visits. 9 video visits completed. And I think this highlights some of the gaps that the new COVID might bring in terms of access and equity in terms of telehealth and virtual visits. All our visits, ED visits, and inpatient admits went down, and you can kind of guess why that might be. And so in wrapping up, there was loss of social supports, connection with team members, higher rates of return to drug use. I think loss of structure and continuity of care with team members, increase in violence downtown and unsafe environments for our clients. Again, social services and outreach impacted our roles, and loss of cohesion, burnout, and stresses on the FQHC systems. And so on reflection, the populations we serve are highly stigmatized and marginalized. People impacted by homelessness, substance use, mental illness, and complex pain don't fit in traditional healthcare systems, and this has resulted in loss of trust. The Summit team helped build rapport that led to empathy and establishment of trust. And Summit does not fix structural, institutional, racist policies and systems that cause these disparities, but what I'm learning is that this intervention can allow space and time for patients to re-engage in healthcare systems, develop trust and support to reduce health inequities and improve quality of life. And the next steps are to improve scalability and feasibility of these interventions in times of uncertain sustainability and financial stability of FQHCs.
And just a little ping on time.
This is it. I just appreciate your time. And I just want to highlight Dr. Kuchel, who was my mentor in fellowship, mentioned this article about that these readmission programs, maybe we're assessing or judging these programs by the wrong metrics. I appreciate your time.
Thank you. Thank you so much. Next, we're going to hear from Dr. Seth Pickens.
Hi, everyone. Good afternoon. And in a car. I may turn my video off here as we get the screen going. Thank you very much. Thank you. So, I mean, the folks who are still here, this is hardcore homelessness policy people, all right? So I know I'm talking to the right crowd. So my presentation is called Human Empowerment as Systems Change, and we're talking about homelessness, housing insecurity, and of course, racial and ethnic equity during COVID-19. Of course, that's what we're here for today. So I'm Seth Pickens. I'm privileged to serve as director of the Realization Project, which has spun out of the Economic Roundtable, which is a research firm in LA, Los Angeles, that is committed to knowledge for the greater good. Next slide, please. So I want to explain what we're doing a bit here and what makes this an innovation in particular. This is an innovation that is tackling one of the greatest, probably the greatest crisis in higher education right now, which is housing insecurity, of course. In particular, we're zoned in with the community colleges, California community colleges. Imagine 2.1 million students, 1 in 5 are dealing with housing insecurity. So that's almost 500,000 just in the California community college system of people dealing with housing insecurity. Many are sleeping in cars. So this project, we're working specifically right now in our infancy, in our pilot phase with Long Beach City College. And they have, those in California, if you're familiar with AB 74, which was funds for housing for college students. And there's been quite a few initiatives. Long Beach City College is leveraging those resources and providing housing to many of their students who are dealing with housing insecurity. That's wonderful. What's missing and where the innovation comes in is that, I think we all know this, just giving someone what we would call a bed and a pillow, a roof and a pillow, does not speak to the medical, to the socio-emotional, to any of the other things going on. Roof is still key and housing is key. So when we place people say, well, you're homeless, get them a roof, and then they're not homeless anymore, problem solved. But as some of even the other presenters are speaking to, obviously we have other issues. So we're taking a holistic or a comprehensive approach where, yes, if someone's homeless, they need a roof, but just housing placement is not really affecting the change that we know we need affected. So we're using, yes, housing, also workforce development. Workforce development is great, gets people equipped, gets them trained, gets them plugged into high road careers. That's fantastic. Still, we know workforce has not been so successful, has its shortcomings for sure. Same with mental health. Let's make a mental health placement. Let's put someone in therapy. That's great, and it does help. Therapy isn't helping a person know all of these situations. So exists at the intersection of higher education, workforce development, and homelessness services. And we could actually include behavioral health services in this Venn diagram also. So with this, what we're calling a holistic approach, a comprehensive approach, or a heavy touch approach, we are finding success. We just finished our first cohort in the 2020-2021 school year with Long Beach City College, and I could, give you those results, but been very, very positive from a mental health perspective, from an employment perspective, from a housing placement perspective, and I think it's doing what we want to do. Next slide, please. So this kind of explains, I think we know this. Hopefully I've been able to put this into a unique articulation. What is wrong? And then I'll get into what the Realization Project's doing right so far. And we still obviously have a lot to learn. But what's wrong? Right at the center of this framework, what you see is the largely untapped human capability. Now, when we want to talk about race and we want to talk about equity, you have to talk about the untapped capability. Just because people speak in, maybe it's Ebonics, maybe it's, maybe their mother, never had a bank account. Maybe that doesn't mean that intelligence, genius, potential, and possibility is not present. And a lot of times what happens, if you look at that top left orange arrow, just being in this line of work, there's hierarchical relationships. The social worker is kind of looking down at the homeless, quote unquote, client. But that's one of the things that leads to this perceived incapability, which becomes a self-fulfilled incapability on the part of clients. So by the way, for the record, our project does not even we don't use the term client because it implies a hierarchical relationship. We just call folks project participants. So that hierarchy is unhealthy. Over to the right, institutional inertia, whether it's county government, whether it's social workers, it's different. I know we got people from all over the country here, but in Los Angeles County, we have county, we have city, we have homelessness authority, we have all these folks, we have higher education, we have medical complex, all trying to work, stepping on each other's toes. There's different cultures, there's different ways. We got the city suing the county over homelessness right now. So that just speaks to the institutional inertia. Systemic injustice, which we talk about, race, equity, of course, we know. And then also low cost, no cost resources are necessary sometimes, but they can actually lead to, again, dependency, and back to this, all of these factors. So those are 4 factors that are leading to perceived incapability, and which becomes a self-fulfilled incapability, typified by dysfunction, disempowerment, despair, and dependency. Last slide, please. So our approach here, very briefly, we start again with that human capability and that potential in the center, and we are approaching it in these ways. Pedagogical collaboration, your pedagogy, your teaching. What folks learn is what leads to the change. They come into your program, and when they leave the program, they come out on the other side. How are they different? Yeah, they had a house for 6 months, great, or whatever, but what folks learn is what they're able to take with them. So pedagogical collaboration, trauma-informed care, of course, goal orientation, which is just applying, basic, let's write down the goals. What are your goals for housing? What are your goals for employment? What are your goals? And then cultural imagination, valuing where people are coming from. A person with a master of social work, a doctor of social work, or whatever, a medical doctor, does not automatically know better what's best for a person just because of those degrees. So where people are coming from, they know the situation. And Einstein himself said, it's not even that I have the answers, I just am asking the right questions. So respecting people where they're coming from, asking the right questions, not assuming we know. It's been a wonderful intervention. I could talk more about the outcomes and things, which have been very, very positive, very positive. We're looking to scale. It's going well. And I'll wrap it up there. Email me with anything further. But thank you so much.
Thank you so much, Dr. Pickens. And our last speaker for this session is Raven Drake, speaking from Street Roots. Welcome.
Hello, everyone. I have no fancy slides for you. I am just a simple outreach worker. My journey into outreach is much different than most of the people on this call. At the end of 2019, beginning of 2020, when I arrived in Portland, I was unhoused. I was homeless, and I came to work at Street Roots as a vendor. And very quickly we saw this virus already take hold and start in Washington. I knew it was only a matter of time before it reached down to us. And so, we started to look around at the outreach that was here. And I went to planning sessions with Kaya Sand, our executive director, as her guest. And I started to realize that the plan of sheltering in place was effectively the abandonment of the unhoused community. And when we had the first case on March 11th of 2020, and we swung into action with our action team out of Street Roots, which was the predecessor to our ambassador program, we saw just that, a total shutdown effectively across the city overnight. Total care providers had to scale back and had to shelter in place. They had to change the dynamics. as Dr. Chan talked about, the personal engagement with people just really disappeared almost overnight. And, you know, I knew the disparities of how the unhoused community were engaged with this effort. Our ambassador team is very unique to anything else in the city or even most of the nation, as myself, who, you know, I created the program and I manage the program at this moment, but every single member who is an ambassador, who goes out and does this outreach in that community, every single one of them has experience being houseless or is houseless themselves. The entire team is made up of people that can relate to every situation we're about to walk into. Half of my current ambassador team suffer from mental health issues and have a history of drug addiction. We're able to sit down with people and guide them towards partnerships that we have and other resources. The vast majority of what we do in the ambassador program is to centralize that voice of the unhoused community and to change how civic engagements happen. You know, we're fighting an epidemic of indifference. That's what perpetrates all these things. You know, indifference perpetrates the disparities we've talked about today in the healthcare system, in the education system. And it's what perpetrates those same inequities that we find across homeless services and resources throughout the city. People have been historically blocked from these resources. And instead of investigating whether or not that resource is available to them, they know that their uncle or their father or their grandfather or their grandmother couldn't access them. So why should they try? We find that same reliance on certain systems, but not others. And so the purpose of the ambassador program is not only to be able to speak to those inequities, to housed or unhoused communities, but is to be that bridge, those liaisons, to take those stories back from the street and work with partners, with care providers, to advocate for people. And to make this team entirely unhoused individuals was a new thing, was to show that the capabilities of that community is far beyond what we have understood, what people have understood. I mean, before I became homeless in 2019, I knew nothing about the community. I knew what I saw in the news. I knew what I heard from people. And you know the examples that you see on a Mac stop of somebody going through a trauma, a crisis moment, or, you know, the images of of people sitting outside their tent that we see on the news. But that is the tip of the iceberg to the story of who's out there and the chemical makeup of what makes that unhoused community. We have found that that community has even surprised us who live there on exactly the depth and the integrity of it. We're now in our second ambassador team. The first team, it was the mission to show that we could do this. And so much so that more than half of my team was immediately hired by Greater Good Northwest, who is a sister organization to Do Good Multnomah, to work in their shelter system. And those ambassadors who are now being given the chance are thriving and becoming leaders on those teams that they're on. And it's our goal with each group to give them this stage to show that there can be new outcomes and new programs that can be very grassroots to move people. With all the multitude of services that we had here in Portland, the one service that has never existed has been a pathway off the streets. We have a pathway into treatment, we have a pathway into housing, but there was no pathway that let people architect that next chapter in their life. And that is the goal of this program, is not only to work together around civic engagement and community engagement, but to build an internal program that allows people to architect that next step in their future, to decide what they're capable of and where they can go. Some of my ambassadors left to PSU and are now enrolled there in school. And I've been very thankful for this, a very close-knit relationship with the HRAC program at PSU, and being able to rely on each other around, you know, a lot of the information that came in the HRAC over the last year and a half has come through my ambassadors. We've been able to have a very fruitful partnership where we're already out here on the streets. We're able to go and get the information they're looking for, and they're able to process it and help us organize it to be able to relay that information back to communities and say, here's what we found. And so I'm really going to stop there because I think I don't want to bore you with too many of the specifics of the program. And I look forward to the questions.
I'm going to go ahead and start our Q&A in just a moment as soon as folks return to this room.
Please feel free to start dropping those questions in the chat.
Yeah, good reminder. I know y'all have lots of good questions and thoughts. We want to make sure that we uplift them all. All right. Okay. Awesome. All right, folks. So you know how this goes because we've been doing this all day. We are in our final Q&A for session 3. So we're just going to go ahead and the question. So the first question is for Chris. The question is, can you detail what street outreach looks like and where you are? And do those services or the people delivering them vary based on racial identity? Oh, you're muted, Chris.
Sorry about that. I should learn after a year and a half of this. I should know better. Street outreach is a very interesting component of the homelessness response systems, but if you look at all the continuums, it's only really aggressively applied by about 25 to 30% of them. So it's not all that frequent. So street outreach involves hiring workers, and in some places they have multidisciplinary teams that would include a social worker, a mental health person, a nurse practitioner, or some other healthcare provider. In other places, it's just a single individual. And the goal of the outreach workers is to go out and to engage with people who are experiencing unsheltered homelessness, try to build a relationship with them to the point where they may be willing to go into a shelter, but if not that, to try to find some other solution to their housing problems. These people in Sacramento, where these data are taken from, there are hundreds, if not thousands of people who have lived in, unsheltered for 5 to 10 years. So these are people who are very difficult to engage, very resistant to thinking that the system will provide any help to them. The outreach workers have come from a variety of backgrounds. A lot of them are young, newly minted people with master's degrees in social work. That's one avenue, but I would say more than half of them were people people with lived experience. And those were the people that I really was most impressed by, that engaging with someone in homelessness had completely transformed their life, and then that enabled them to connect with people in ways that would have been extremely difficult for someone like me to connect with. In terms, they come from all different gender, racial, ethnic backgrounds, but in some ways, my experience was that race and ethnicity made less difference than sharing that experience of being hopeless on the streets and understanding and being able to interact with someone who had gotten housed again and to turn their life around.
An additional question, along with earlier, this one specifically is ambassador different or unique from other similar?
You're cutting out.
Okay, let me try again. Can you hear me now?
Yep.
Yes.
Oh,
Graham, different?
Sini, it is happening again, I believe.
Yeah.
I'll go ahead and ask this next question and then.
I can see it in chat, I have the chat open.
Oh,
Yeah,
yeah.
Richard, that's a great question. So the biggest ways that my ambassador program differs from many of the other similar programs is that what Chris was just explaining, that there's a large proponent to most of these street outreach programs that are professionals. We think of the makeup that we built with Portland Street Response and their outreach, and these are EMTs and mental health specialists and community health workers. And we think about outreach teams like Portland Street Medicine, full of doctors and nurses. PPOP, most of them are nurses or EMTs that volunteer in through that system, or people with that lived experience. But lived experience is only ever really a small component in most of these outreach teams. What we built with the ambassador program was a team that does not rely on a professional background or whether or not you have a degree or you work in social work, but of lived experience being the central focus of a mission into the program. When we go out and sit down with people, we focus on that lived experience, that shared lived experience. It allows us to access camps and parts of the city that no other outreach team even goes to or dares to go to. You know, we've gone to camps that are by most outreach communities slated as too dangerous to go into. And I've been into them with my ambassadors in the evening, when it's going dusk and most people are bailing out. We feel comfortable in these situations, but for most of us, we live there. We're known on the streets. We have families and communities out there. And so that lived experience opens doors and bridges so many gaps that many outreach teams can't do. And it's my hope for the future that that the people coming through my program get to find spots on those other outreach teams to kind of bring that bridge into them, but that as we reach the other side of this pandemic, we as outreach workers across the spectrum of training and background and education decide to come together and centralize all of our voices, no matter the background that brought us into outreach, but just the fact that we are outreach workers.
Thank you so much, Raven. I really appreciate your focus on the shared lived experience and the need to really connect and ensure that people are in positions where they hold a lived experience with the folks that they are serving. It's so incredibly important to these kinds of peer-delivered services. There is another question for you, Raven. I can also swap it out if you need a little bit of time. Okay. So the question is, what do institutions like PSU, like OHSU, et cetera, need to know about community-based collaborations?
Oh, that's a good question. I think what they need to know about community-based collaboration is that it comes in every form, shape, and size. You know, I had the benefit of starting my outreach team with a well-established organization like Street Roots. But through the pandemic, we saw outreach things start across the city that came from very humble beginnings. And that some of these teams, some of these makeups were in communities where they were 1 or 2 people. You know, we saw the development of the PDX free fridges go widestream. We saw things like Hygiene for All come online. We saw the expansion of camps and housing groups come to be. And what we came to realize was that there is no actual blueprint for a community, organization. And so what the institutions have to realize is that when someone is working in a community, much like someone being unhoused, there is no status quo to what that person looks like or comes to them as. And so that we have to be more opening and welcoming to people of, who have these different ideals, these nuances, to come into our organizations and show us new pathways.
Mm-hmm. Thank you so much, Raven. And there's another question. Let's see. It says, and maybe Chris and Brian, you can answer first, and Raven, if you've got some feedback, that would be continued feedback, that would be great. The question is, are folks working with community health workers or other traditional health workers? If so, can you share about some of those strategies?
You like to start, Brian?
Sure. Just so I understand the question, though. So are folks, meaning clients or people in homelessness working with these community health workers or our programs, you know, if it's from the medical side, the summit program, we have our social worker is basically like a community health worker model, and in that they do the outreach and while the community health worker model is actually, you know, as Raven alluded to, is by definition a lay person. Central City has hired people with some training, and so there's I think there's some debate whether that's actually the best use of it versus someone with you know, perhaps more lay person or lived experience. But we do have those people that come out, and I think that really adds to the special sauce of our intervention. Is again, you know, I think it's easy to say meeting patients where they are, but I think harder to do when there's such power differentials with medical people and being, you know, having patients come into an office space. That's when we talk to our clients about that. It's really intimidating, and it's not necessarily patient-centered. That's one of the things that I think this intervention really aided in, and kind of in the context of a health system that really is working against that. I'll stop there.
Los Angeles has invested heavily in these what they call multidisciplinary teams, which do bring out community health workers out into the field. I think just extrapolating from my research, what's really kind of powerful is, are there ways of meeting people where they are at in ways that can make them more receptive to working with people to help resolve their problems? We know that emergency shelters are not a very positive environment for most people. There was a researcher in Los Angeles that just did a paper, and he found that staying in a shelter had zero impact on whether you got housed or not eventually. So that's not necessarily a very good method. This is not something for everyone, but it is a model that for a very large unsheltered population, especially here on the West Coast, that is very resistant to going on to shelters. And I think that there's a lot more to be examined in how we can use that type of work effectively.
And can I just hear the question again to make sure I understand what was asked?
Yes, absolutely. Absolutely. The question is, are folks working with community health workers or other traditional health workers? If so, can you share about some of those strategies?
Yeah, so we work across the spectrum, not only by ourselves. Most of us, you know, I have a unique way in which I do outreach. I'm a former Navy corpsman. I spent 3 combat tours in Iraq with the 1st Marine Division. So I tend to go out with my medical bag, and I have for some time, but that's a training that I have. Most of my ambassadors don't have that training. They just have their own goodwill of being able to sit down and talk with someone. Many of them have taken an interest, and we had the first group, we have more than 5 of my ambassadors take classes that we paid for through a grant to become peer support specialists. So, you know, it's about opening up our arms and our doors to people who have not had that traditional. We have found that the institutions can be quite rigid when we talk about credentials. Okay, what are the credentials of this outreach team? What do they bring? Are they social workers? Are they community health workers? And what we found through surveys that we've done with ATRAC through our own outreach is that it means nothing to the people living on the street. You'd come out there with 30 doctors or 30 outreach workers who just have lived experience. And as long as they're being talked to, and as long as they're being taken through resources, as long as they're being given resources they need, as long as their voices are finally centralized and they're able to have that moment to talk about what they need, they don't care who they're talking to. And so we have to kind of step away from this model where we, I would love if I could get people, who would come out with us who had those backgrounds and that makeup. And I have had a great many of them who have come out and done outreach with us. I've been able to go out with Portland Street Medicine and do outreach. I've been able to walk around with a great many people, and I got to interact with a lot more of these people when we built the C3PO camps. But what we have found is that to the people living out in those tents, to the people who are living in their cars, who are unhoused and going through uncertainty, it doesn't matter who or what credentials you have, but that you're coming out there to see them. And so I think it's a time for us to reflect coming towards, hopefully, to the other side over the next year of this pandemic, or maybe more, that we start to look at the makeup of our own teams and decide what is our priority, because we can either prioritize the makeup of our team and whether or not somebody is credential, or we can prioritize the people we're serving, but it's hard to do both. And I think it's more important these days and age that we prioritize what we're bringing to the people and not so much how that's delivered.
Thank you so much, Raven. So much of what you're talking about, I think, really gets to when we talk about, racial justice informed health and equity practices, we're talking about mitigating for power, right? Dismantling some of the ways in which hierarchy leads us to believe that people need certain credentials to be able to do certain work, when we're really getting in the way of actually just doing the work. So I appreciate you very much, Raven, and bringing that up. We've got a couple more questions here. One, I think this is based on a point in your presentation, Dr. Ware. What could community-driven metric creation look like, and might this mitigate for some of the different metrics lead to different conclusions point in Dr. Ware's presentation?
I'm not exactly sure what you mean by community-driven metrics, but trying to address homelessness is really quite multidimensional. So I will say, that having a good set of metrics is really important, but when you look at improving quality of life, empowering people, ensuring that people are housed, whether they have the resources to get back to work if they have that capacity, those are all dimensions that you're trying to achieve in all this, and then they are all important ones. Now, I think that some of the metrics that you really want to look at are, were the people that were helped by street outreach workers, did they feel heard? Did they feel validated? Were they moved into a place where they felt like they could resolve their own problems and empowered? So those would be some of the metrics that are much more difficult to capture, but could be captured by the community, and would be very important to feed back into a system as you were trying to create an outreach program that really showed a high level of cultural competence. But I think that actually Raven probably has can speak with a lot more expertise on this topic than I can.
I still laugh whenever anybody says I'm an expert. I don't view myself as an expert. I just view myself as a loud voice that wouldn't go away until someone listened. Man, I enjoy. Okay, I enjoy doing outreach, and I do enjoy doing outreach with people who enjoy doing it. And a lot of them have backgrounds that are traditional community health workers, are, people who have been in these roles and operating outreach in the community. I've gotten the benefit of working with a great many people who have, some of them for the last 2 decades made outreach their calling here in Portland. And so I've gotten to really learn from people that I consider to be the experts. And, like I said, what I learned is that outreach is accessible and capable of anyone doing it. and it should be as equally accessible to anyone to receive it. We noticed that same thing that when we would do surveys around outreach with HREC, that, you would get a lot of responses and people, a lot of these surveys were centralized in the downtown area, the old town area where there's a lot of services, but not many people went out to talk to the people off 174th or whether or not they access resources, or went out off of 90th and Foster, 92nd and Foster, or went into the Sunnyside neighborhood. And what we realized is that the further out of downtown you got, the less a lot of these researchers went and talked to people, the less outreach went to talk to people. And outreach, if you lay out all the outreach in Portland on the map, you will find these giant gray areas where nobody does outreach. It's outside of their area. I illuminated this to Molly Pringle, who's the executive director of Portland Street Medicine. We were out doing outreach one day and we were inside their normal area. And I said, I give you $10 if it isn't so. And I walked her 5 blocks from the outside of their normal area. And nobody living in this encampment that we found could even tell us who Portland Street Medicine was. And that's what happens with a lot of the outreach, is that because we don't overlap on each other, because we're not reliant on talking to each other, on building those networks, because we become isolated, that our areas become that isolated, and that somebody living just outside of our areas never heard of it. Everybody downtown knows who Street Roots is, and we're pretty universal across the city because we have that presence. But, a good example is I can take you in the neighborhoods, Dr. Chan, where no one's even heard of Central City. And it just exists like that through even our own city. And we have some of the largest networks of outreach workers, of programs, of services in the nation. Some time ago, I came from Columbus, Ohio, that has next to nothing. They have almost 5,000 people who are unhoused, and they have not even a quarter of the resources we have out here. Okay. And so, I implored friends of mine to just take up the banner and go out. Outreach is as complicated or as simple as you want to make it. I'm in the process of teaching this new group of ambassadors to do outreach. And the first thing I taught them to do was just to go outside and sit down and talk to somebody. Most of them who lived unhoused, it sounded stupid to them because it's something they do every day. But how many people actually go and sit down next to somebody at a tent and ask them how their day was, right? The problem with the epidemic of indifference that we fight against as a community is that it becomes too easy for us to look at our phone or think about a conversation we're having and walk to that max stop past 100 tents and never even look at them. It becomes normalized to us. And once it becomes normalized and we take away that human aspect, the necessity to fight it is taken away. I heard this saying in a meeting, and I think it's very true, that there was no profit in solving homelessness, because if there was, every corporation in America had solved this tomorrow. All right. And so that's the kind of thing that we fight against, is that all of us in this larger community, through healthcare, through social work, education, all of us who combat homelessness in all the different ways that we spoke about today, we are that minority in this larger nation. For a great many people, their understanding of the houseless community is someone said that someone was homeless on the news, and that's all they know. A great many people can't even name one person that they know who have experienced it. And it's that cold indifference that continues to perpetrate this throughout the nation, throughout the world, is when no one's invested in that group of people, then it's easy to ignore that group of people. And that was the beauty, kind of the silver lining out of this pandemic, is when it stripped away, when people had to not shelter at home and not go to work, and that uncertainty set in for them that is a standard fixture within the unhoused community, it caused them to take a pause and look at the system, at the cracks, and it caused them to sit down and go, wait a minute, I am only a few paychecks away from being right there. And for a vast majority of this nation, there are 1 or 2 bad months loss of a job and not being able to get workman's comp or unemployment from finding themselves in the same situation. It's now what we face with the end of the moratorium on evictions is how many people nationwide will get caught up in that and join those who are unhoused without some kind of safeguards in place. And so I think I'm less concerned, and as somebody who has lived out there, as somebody who tries to bring outreach to people in the way in which I wish outreach would have come to me, I think it means less to us out on the street of whether or not somebody's a traditional healthcare worker and more that they're there to help us.
So many thanks, Raven. And you actually, we have this kind of last question that we were going to prompt folks with, and you so brilliantly and intuitively began to answer it and answered it already. So I'm still going to pose the question. And if any of the panelists want to reflect on it, please, please, please do. And the question is, where in your work do you see more opportunities to center people who are experiencing homelessness and to build solutions in collaboration with individuals and communities?
I'll take a stab. I mean, I think in my work, I think as I alluded to in my presentation, what started as a hospital reductions program and a cost savings program is really, I think what I've learned is just this opportunity, this realization that that we as a healthcare system, as a society, have really ignored our people undergoing homelessness. And I'll speak from the healthcare system. I mean, I think there's a lot of talk about it, and Raven and I were talking in our small group about COVID has actually accelerated this conversation. I think that's the silver lining, is that there's kind of this interest in this work because of what Dr. Kushel mentioned this morning about the disparities in COVID risk and vaccinations in our homeless populations, and that in our qualitative interviews, these patients have had years of trauma and stigma with healthcare systems that I think maybe I was being naive, that just not realized. I think when I went to medical school, it was this great equalizer, and that we treat everyone equally, and that there's just so many structural systematic things that do not kind of permit that. And so I think what I've learned from Summit and work with these interventions is to try to, like I said, they're not silver bullets. I think the intervention can't fix the ills of society, but I think what I've learned is that we can do better as healthcare professionals. Is, like Raven said, like, it's not even about the title. It is having empathy. It is really talking to people, meeting them where they're at. I think that could go a long way to bridging trust, because I see it with the vaccinations issues. Our patients have a lot of different reasons why they might be hesitant. And it's not just that they are one political leaning or one form. There's a lot of kind of trauma. There's been kind of past experiences that have led to mistrust of healthcare, traditional healthcare. And I think it's our job to understand that and to kind of almost sit there, and we do that with addiction care. We don't mandate people to get on drug treatment, although that, we know that that's kind of our evidence base, but we try to meet people where they are and give them different options and different choices. And so I think that's kind of the lesson I'm taking from all this.
Thank you for that, Brian. A lot of food for thought there. Chris, any thoughts before we close out?
Well, I will just quickly say that I'm constantly surprised about how little we listen to the people that we're trying to help. COVID has made it very evident that there's a strong preference for single room shelters versus congregate shelters. If you listen to people on the street, there are many people on the street who actively fear going into shelter. It's not that they don't want to, they actively fear and loathe the concept of going into a congregate shelter. We're working on safe parking programs in Los Angeles. These parking programs close you have to move your car off of the parking lot at 7 a.m. The first thing that everyone has been telling us is that we want to be able to park longer or all day long, and created a community where we're parking. No one asked them before they designed the parameters of the program. So it's not rocket science, but it is an incredibly important thing is to seek out what type of help that people who are experiencing homelessness really want and need.
What an amazing group of presenters to end this day on. And you all are leaving, I know me, and I'm sure everyone else, with so much in our minds and hopefully in our hearts as well. I just want to thank you, really, everyone, briefly from the facilitation. An amazing time here today. I'm going to send it over to Dr. Zapata, who will close us out. And if folks have any additional questions or anything, feel free to put them in the chat. We can make sure that they're collected.
Thanks, Ania. And I'm ignoring the fact that everyone's dropping off. I'm going to say my awesome remarks for closing anyway. This was really great set of presenters and presentations and questions and chats. And I really hope that everyone took something new or something inspiring or something that challenged them away today. I encourage you, after we get off today, to spend a few minutes just sitting in your body, taking a couple of deep breaths and reflecting either on what you've heard or honoring the fact that maybe you're feeling overwhelmed and tired and dreaming of happy hour drinks. For me, I just want to say that I'm reminded that in the last 18 months, things have been really terrible, and that I think most of us have just dug in harder, right? And I don't want to celebrate the workaholic culture. I think it's a little bit different. I think that particularly those of us who are from some sort of marginalized community, that's what we do, right? We know that we have to be the strength for one another when in fact things are crumbling even faster and worse. And so we have had all of this great new learning and challenges the way we are thinking about things. And I don't want to be Pollyannish about it and say, hey, these great things have come out of this terrible thing. I don't think that's true. I think we've done what we've always done, which is to be resilient in the face of deep adversity. I really want to thank everyone for joining us here today and the entire team that it took to pull off this event. First, I want to thank our funder, Mr. Royce, who actually joined us here today. And of course, Dean Bangsberg for facilitating the connection with us to make this event possible. The ATRAC team, especially Stephanie and Tanya, who have been busting tail to bring this event together. The entire PSU AV team, and of course, Really Big Video, whose studios I'm coming live from. First time I worked outside of my home in 18 months. It's amazing. And of course, really a personal debt of gratitude to our glorious facilitators, Xenia and Katie. I study participatory democracy and doing events like this, and it is terrifying to imagine the people who can come in and bring the commitment to social justice and equity into a space like this. And when someone had suggested them, I was like, yes, this is exactly who we need to be in here. And I am so grateful to them, the ATRAC team, Really Big Video, and PSU AV for allowing at least me to be able to sit down, relax, and really just take in today. So y'all have a great day. We'll get videos out of everything so people can share the great knowledge. And yeah.
Thank you, Dr. Zapata.
Thank you.
Thank you, everybody.
Thank you, everybody. It was a wonderful day.
That's great. Thank you, team. You really did an amazing job. This was a great event.
Yes, thank you so much.